Today we'll be discussing about epithelial pathology and to be very specific, the verrucopapillary lesions in epithelial pathology. Legacy et al. Classified these verrucopapillary lesions into benign lesions, potentially malignant lesions and malignant lesions. Okay, the squamous papilloma, verruca vulgaris and disease and condyloma acuminatum comes under benign lesions. Proliferative verrucous leukoplakia, oral verrucous hyperplasia, potentially malignant lesions, whereas verrucous carcinoma and papillary variant of squamous cell carcinoma comes under malignant category. Moving on to squamous papilloma, it is a benign epithelial lesion caused by HPV 6 and 11. It can either be isolated solitary lesion or in children it may be seen as a multiple recurrent lesion also. The most common sites are palate, tongue and lips. Okay, clinically you see it as an exophytic cauliflower-like papillary lesion mostly on the palate. Okay, histologically you see this pattern with fibrovascular connective tissue core into these papillary extensions of the epithelium. And typical coilocytes, which are squamous epithelial cells with cavitation, can be seen in the histopathology of the squamous papilloma. Moving on to verruca vulgaris, it's caused by HPV2 and it is contagious, common in children. So extraoral sites in your hands and this can be transmitted to your oral cavity along the mammalian border, labial mucosa or anterior third of the tongue. Okay, usually it is a painless papule or a nodule with a rough pebbly surface. Okay, the histopathology of your verruca vulgaris is almost similar to squamous papilloma except for the coupling effect. Moving on to Hex disease, it is also called as multifocal epithelial hyperplasia. Okay, you see multiple papules and nodules coalescing together and giving you a cobblestone appearance. The typical histopathological presentation here is you see mitozoid cells. What are they? They are altered cells with nucleus resembling these mitotic figures. Okay, and you see these confluent club-shaped anastomosing reddy ridges due to coalescing of the papules that you saw in the oral cavity. Next, it is one of the important verrucopapillary lesion. It is oral verrucous hyperplasia. The sequelae is hyperkeratosis, verrucous hyperplasia, then it is your verrucous carcinoma, then comes your squamous cell carcinoma. Okay, between your verrucous hyperplasia and your verrucous carcinoma, you have another entity called as vernaculate carcinoma. Okay, recently added. Okay, we'll be discussing about that. So this verrucous hyperplasia, clinically it is a whitish mass with verrucous or papillary surface. Okay, histologically it resembles your verrucous carcinoma, but then the difference is that the rete ridges, this shows exophytic growth, whereas the retipegs are in line with the adjacent normal mucosa in case of your oral verrucous hyperplasia. Okay, then proliferative verrucous leukoplakia, this has got more chances of malignant transformation. You see white plaques which are multifocal. Okay, multiple areas of your oral cavity will be involved and it is a lesion with high malignant transformation rate and recurrence rate and it is resistant to treatment also. Okay. So histologically, when do you call it as a PVE? Well, histologically it should be with bulky hyperkeratosis, orthokeratosis or corrugated parakeratosis and acanthosis with a verrucous surface and bulbous rete ridges in multifocal areas. Okay, as I said, vernaculate carcinoma. See in your verrucous, this is your normal mucosa, right? Verrucous hyperplasia, you see exophytic growth. Exophytic in the sense the outward growth. No endophytic growth is seen in verrucous hyperplasia. Whereas in vernaculate carcinoma, you see endophytic growth, but then those rete ridges showing endophytic growth are in line with the rete ridges of the normal mucosa. Whereas in verrucous carcinoma, the endophytic growth, can you all see it is below the, it is extending, it is invading into the underlying connective tissue stroma showing elephant foot-like retipex. So this is the histological difference between verrucous carcinoma, vernaculate carcinoma and verrucous hyperplasia. Verrucous hyperplasia, exophytic. Okay, the bulky ridges are in line with the normal mucosa. Okay, vernaculate shows exophytic and endophytic also, but it is also okay, similar to the adjacent normal mucosa, not much of endophytic growth beneath the leafy ridges. Okay, whereas in verrucous carcinoma, the endophytic growth is seen into your invading into the underlying connective tissue stroma, but then no obvious invasion will be seen. There is no breach in basement membrane. Okay, it is seen as a elephant foot shaped rete ridges moving showing endophytic growth into the connective tissue stroma without frank invasion or metastasis. Okay, then this is of course frank CA where you see papillary. This is your papillary variant of oral squamous cell carcinoma, which is a very rare variant with exophytic papillary pattern of growth. So you see papillary growth with fibrovascular cores, okay, covered by dysplastic squamous cells. Okay, so thank you all. So this is the sequelae. So it is your hypoplasia histologically, any white lesion or a patch with verrucous surface or a papillary surface. Okay, might be a hyperkeratotic lesion or a verrucous hyperplasia or vernaculate carcinoma or verrucous carcinoma or papillary variant of your squamous cell carcinoma or frank squamous cell carcinoma. Thank you.